Bipolar disorder is the topic for this video, and bipolar is a very common psychiatric disorder. And very quickly I wanted to actually just talk a little bit about the symptoms, and then I'll go into more detail. But first I wanted to draw a little graph that kind of illustrates sort of the ups and downs of bipolar. And the down, of course, is the depression component of it, and the extreme up here is the mania that is associated, and then this curve here that is slightly lower is hypomania. So bipolar is a mix of mania and depression, or hypomania and depression, as follows. There's bipolar type 1, which is essentially manic plus depression, manic plus depressive episodes. And then you have, of course, bipolar 2, which is hypomanic plus depressive episodes. And these occurrences are quite significant, enough to disrupt a person's social and occupational function, and oftentimes so much so that they will definitely require some sort of treatment, either in the form of medication or therapy. So why does this happen in a person? Why does a person develop a bipolar disorder? Well, it's a combination of quite a few things, one or more. There is definitely a heredity component of it. There's also an established dysregulation of certain neurotransmitters such as serotonin and norepinephrine. And then in addition, life stressors will definitely contribute to the etiology of bipolar. So now let's talk about the symptoms. And first I will concentrate on manic and hypomanic. So mania, basically you're looking at an episode of mania that is at least 1 week. And here are some of the ways of thinking about mania. A person will present perhaps with an inflated sense of self-esteem. Here are some of the examples. An elevated mood or an irritable mood is very common. Decreased need for sleep. Person has all of a sudden these flight of ideas. And I wanted to actually give some examples of some manic episodes as they have a little bit more meaning rather than just a bunch of possibilities. An example of a manic episode is somebody that goes on a big shopping spree and spends a lot of money, or a big gambling spree. Another example is episodes of promiscuity. These are some of the things that will be described on clinical vignettes that will help you identify a manic episode. Hypomania essentially is the same type of symptoms, but they're, of course, as the name implies, they're less extreme. And the criteria for duration is also a little less. About 4 days is what they say. Now let's take a look at the next component of bipolar, which is depression, or depressive episodes. Usually these episodes are at least 1 to 2 weeks in requirement. Your mood will, of course, be depressed. There will be a decrease in interest or pleasure in activities that you used to have great interest and pleasure in. There will be a change in weight, either up or down, and similarly a change in appetite. There might be insomnia where a person can't sleep, or there might be hypersomnia where the person is sleeping a lot. Feelings of being tired, fatigued, and this is a key one, feelings of worthlessness where the person just has these recurrent thoughts of worthlessness and guilt. And then one that I really wanted to point out that's very important is thoughts of suicide. And in the population of patients that have bipolar, up to 15 times greater probability of a suicide attempt than the general population. Diagnosis, it's mostly a clinical diagnosis. It's a psychiatric diagnosis, so lab tests are rarely done. But sometimes if you have enough symptomatology that resembles hypothyroidism, then it's beneficial to check a thyroid level with thyroid stimulating hormone and free T4. And then also, another part of the diagnosis that is important is get a review of any possible illicit drug use, either through asking them questions or by doing a urine drug screen. Because if they are on illicit drug use such as cocaine or amphetamines, they can resemble this same symptomatology. Treatment? Well, generally speaking, you have quite a long list of medications, but for the most part, you're looking at mood stabilizers such as lithium, which is very common. Up to 2/3 of patients who have bipolar are on lithium. Anticonvulsants, interestingly, are also used to treat bipolar. And one example is valproate, which is also known as Divalproex. And then sometimes, if necessary, an antipsychotic medication, such as risperidone. And on clinical vignettes, one of the biggest things I've seen has to do with lithium, and in particular the side effect of lithium, which is hypothyroidism. And if a person is indeed on lithium, then they definitely recommend that you monitor the TSH levels. So keep that in mind, because that's tested a lot. Let's take a look at some vignettes. A 23-year-old male comes to your office accompanied by his girlfriend to talk about attention deficit disorder. He minimizes the concerns she raises, which includes sleeping less, sometimes just 2 to 3 hours a night, rambling on tangentially during conversations, and being highly irritable. When you ask him about these observations, he agrees that they are true and reflect a change in his usual behavior. However, he explains that he is just becoming more social and that his girlfriend is probably jealous of his new popularity. The patient has no family history of attention deficit disorder. His father died at a young age as a result of alcoholism. He denies stimulant use, and a urine drug screen is negative. Which of the following mental disorders is most likely in this patient? Well, let's go through these. Attention deficit disorders usually have symptoms since childhood. So this man is 23 and he's just saying that it's a change in his usual behavior, all these things that are going on. So it's not really a adequate presentation of attention deficit. Generalized anxiety would present differently. He'd be anxious about a lot of things, and his symptomatology of irritable behavior leans more toward a manic or hypomanic episode. Major depressive disorder, again, he doesn't really present with too much of a depression type of a scenario. He presents with manic or hypomanic type of symptomatology. So the appropriate answer to this question is E, bipolar disorder. Next question. A 32-year-old female has a 3-week history of depressed mood. She reports markedly diminished interest or pleasure in most activities, fatigue, diminished ability to concentrate, and insomnia. She has had recurrent suicidal thoughts, but has no specific plan. Further investigation reveals a past medical history of several hypomanic episodes lasting 4 to 5 days, characterized by persistently elevated expansive mood. During these episodes, she needed little sleep, was talkative, met multiple goals, and had trouble keeping up with thoughts that were running through her head. She was treated with lithium in her early 20s, but she stopped taking it because it stifled her artistic creativity. She takes no medication. However, Physical exam is unremarkable. Results from the comprehensive lab studies and urine tox screen is also normal. Which of the following is the most appropriate for her current depressive symptoms? Okay, well, she's got bipolar, but in particular she's got bipolar 2 because she's got depression, but she's also got hypomanic episodes. And that is treated with a mood stabilizer or an anticonvulsant or an antipsychotic. So let's go through these. The first one is a medication that's indicated for people with mania and not specifically for bipolar type of depression. The next one, venlafaxine, is a medication for depression only, but it can throw a person into mania. So for bipolar, not the best drug. Divalproex, definitely. Divalproex and bupropion. Well, bupropion is given for depression only, and it's not really the best medication for bipolar. It doesn't really add much if you give it in terms of resolving symptoms. And lithium and paroxetine, again, lithium she's already been on and she doesn't like it. She stopped taking it. And paroxetine, again, is just for depression. And adding a paroxetine to the regimen doesn't really help or resolve any of the symptoms of depression in the sense of a person with bipolar disorder. Depression by itself, yes, but if a person has bipolar, then your best bet is medications like Divalproex. So that is by far the most appropriate for this patient. And then finally, for a patient on lithium for bipolar, monitoring should include periodic blood levels of lithium, creatinine, and which of the following? Well, remember, one of the side effects of lithium is hypothyroidism. So they definitely recommend that about every 6 to 12 months you check a TSH level.